Is now starting. All attendees are in listen-only mode.
Hi, good afternoon. Today's December 4th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Our presenters for today include Bernie Simons, the Deputy Secretary for DDA, and we'll also be hearing from Regional Directors, Kathy Marshall from Western, Kim Gescheidel from Eastern, Bianca Renwick from Central, and Onesta Duke from Southern. We also have Chioma Ani, the LTSS Program Manager, and Valerie Roddy, Director of Fiscal and Operations. And helping with Q&A would be Patricia Sastoque, Director of Programs, and Rhonda Workman, Director of Federal Programs. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode, and there is a handout for this webinar, and you can find it in the handout section in the panel to your right. They can also be emailed upon request. We will be recording the webinar and posting it on the YouTube link on the DDA website. Questions can be typed in the question or chat box in the webinar panel, and we will answer those towards the end of the presentation. And now I'd like to introduce Deputy Secretary Simons. Good afternoon.
Good afternoon, and I want to thank everyone for their continued support for attending our webcast. I hope everyone had a safe and healthy Thanksgiving, and I'm sure it was nothing like you've been used to in the past with family gatherings, etc. But again, I hope it was very enjoyable and that you had an opportunity to get some rest and relaxation. Thank you. Next slide. So as we remain committed to supporting for the health, safety, and well-being of the people that we provide supports to, their family, staff. We still know that this is a critical time. Obviously, seeing with the rising in the number of cases that we've seen within the state and across the country within the past couple of weeks, it's just amazing that the numbers keep growing. If you watch the news, you'll see that many of the states are at a very, very high capacity on their hospital beds and ICU beds. So I think we as a DDA community in Maryland have done an outstanding job with the number of people who have not been positive for COVID-19. So I'm going to ask everybody to continue to practice your social distancing, washing your hands, and limit and stay away from any large gatherings so that staff and individuals and families that we provide supports to will continue to remain safe. Next slide. So you may have seen the governor earlier on in the week. Obviously, there was a press conference, and you have heard that Dennis Schrader will be the acting secretary as Secretary Neal retired effective December 2nd. And so the current surge is affecting, as we know, our direct support professional workforce. And I just want to remind everybody that the providers have several options under the approved Appendix K that CMS approved for us related to staffing, such as hiring family members of individuals as staff, hiring requirement exceptions, and requesting staffing ratio exceptions that might help. We know that X amount of people who are either testing positive, or if they haven't, they're quarantining, and then aren't available to be part of the workforce. So we ask again that you take a look at the Appendix K and what we have put in there, and work with your regional offices again for assistance. And the regional directors would be more than happy to work with all of our providers who are in such a stressful situation with this COVID-19. Next slide. Tanya.
Yes, thank you, Bernie. So with this second surge, providers, families, and people in self-directed services are asking about personal protective equipment, PPE. The DDA has given out 5 rounds of PPE across all regions, and we requested another round that will be distributed to the regions by the end of next week for microboards, individual and self-direction, and providers, with Western Maryland Regional Office actually getting a delivery today. So if you're having a hard time getting PPE from your local health department, please contact your regional director. Providers are also urged to advocate at their local level, as the governor has encouraged county leaders to utilize some of their remaining CARES Act resources to build up the supplies of critical PPE, particularly gloves, gowns, and masks. Next slide. The department has amended the order regarding various healthcare matters of patient surge. This order is critical as it talks about the surge capacity in hospitals. Testing. Please know that people you support can get tested by their primary care physician in their local testing sites across the state. We have attached a link with information on the testing sites. Next slide, please. So now I'm going to talk a little bit about the vaccination plan. So Maryland's draft COVID-19 vaccination plan focuses on 2 major phases of vaccine distribution based on availability, and we've included the link of the draft plan. Phase 1 applies when there's a limited vaccine available and will focus on priority groups to receive the vaccination. Phase 2 applies when there's a wide-scale vaccine availability for the general population. The department will follow the recommendations of the CDC Advisory Committee on Immunization Practices, ACIP, as to who should be prioritized to receive the COVID-19 vaccine. Next slide, please. As noted in the Maryland's draft COVID-19 vaccination plan, which you can find it on page 45 in Appendix 3, the vaccination priority group includes Phase 1, high-risk healthcare workers, first responders, older adults in congregate settings, and people with specific comorbid and underlying conditions. Phase 2 includes teachers, school staffs, childcare workers, people in homeless shelters and group homes, including staff, and people 65 and older. The department anticipates receiving recommendations from CDC soon on priority for the vaccine. Next slide. Preliminary Phase 1 and Phase 2 priority groups were determined using recommendations from the National Academies of Sciences, Engineering, and Medicine, and other partners. So until MDH has a better idea of the number of doses and the method of giving out the vaccine doses, we are unable to speculate as to exactly which groups will get the vaccine first. But DDA will continue to advocate for individuals with developmental disabilities and their staff to be priority. So now I'm going to turn it over to Rhonda Workman, our Director of Federal Programs, who will give you an update on DDA's Appendix K and Amendment Number 3.
Thank you, Tanya. Good afternoon, everyone. So for our Appendix K, we wanted to share an update and remind you that we are partnering with Medicaid, the CMS, the Center for Medicare and Medicaid Services, and our National Association of Developmental Disability Directors to continue to look at all the flexibilities and options through Appendix K. We are currently actively working with CMS and our Medicaid office to remove the requirement for consecutive days in our Appendix K so that providers can access up to 30 total days and not have that consecutive day requirement. We will share additional information and guidance once it's available and update our information and guidance on our webpage. We will also look to extend the Appendix K if it's a federal option. Currently, under the Appendix K federal authority, it's available for a period of up to 1 year. We have been sharing updates in our webinars and stakeholder meetings that CMS is currently looking at this limitation and exploring options to have for states to extend. Once we receive information about the options that are available, we will coordinate with our Medicaid office to ensure that we have the most flexibility for our providers. Next slide, please. So since the surge, or since the current surge is affecting our direct support professional workforce, We wanted to talk a little bit more and refresh information related to these Appendix K flexibilities that the Deputy Secretary had mentioned. Those options such as hiring staff, the hiring requirement exceptions, and requesting staff ratio exceptions. As a reminder, the DDA has a dedicated Appendix K page for which we have specific memos and guidance related to the authorization under the emergency authority that we can use. On this slide, these are the links to the ones that we're going to review. Next slide, please. So the DDA Appendix K number 6 is a guidance that's specific to staff training and onboarding flexibility. It includes various hiring flexibilities for providers to explore and consider as they look to address the current surge and a need for additional staff. Services by relatives or legally responsible individuals is an option for our providers. Providers are encouraged to work with participants and their families to explore the availability of natural supports if needed. And in the event that natural supports are not available, providers or participants enrolled in the services, including the self-directed model, can hire relatives and legally responsible individuals to deliver staff. In other words, you can hire them to be an agency staff member. Another flexibility relates to the exception for staff age requirement. Individuals 16 years of age or older, including family members, neighbors, certified providers that meet revised qualifications as set forth in the guidance, can provide direct support for waiver program services that normally would require the direct support professional to be 18 years of age or older. Another hiring exception relates to the requirement for high school or GED requirements for staff. Some of our services require that the direct support professional to have a high school diploma or GED certificate in order to provide the waiver services. During this public health emergency, these requirements can be waived if that's a selection by the provider. In addition to criminal background check requirements, a provider who chooses to utilize non-traditional staff in direct support positions must initiate an appropriate background check, an MVA check if the person is driving, but may place the staff person on the schedule immediately after performing an abbreviated background check using the name, birth date, and social security number of the potential hire. Additional flexibilities in terms of hiring relate to training requirements. To expedite the hiring of staff and their ability to work with participants immediately, the DDA temporarily waived all but the most essential staff training requirements for direct support professionals under both the self-directed and traditional service delivery model. You'll see, in addition, training requirements may be waived for family members willing to provide services to participants until 60 days following the end of the state of emergency. Registered nurses are temporarily exempt from receiving training from the DDA regarding delegated nursing until the state of emergency is terminated. And our policy on reportable incidents and investigation training may be provided in a condensed form and must include a minimum the definition of reportable and serious incidents and the procedures for reporting. A few additional exceptions for the hiring process that providers can utilize includes the waiving of the health screen and PPD tests. Providers may waive these tests as a condition of employment for their direct support professionals, including legally responsible family members. And finally, there are exceptions to Maryland professional licenses. Providers may temporarily waive certain license requirements for the healthcare professionals in accordance with the executive orders issued by the Governor of Maryland. Providers may also continue to use staff with an expired license and other authorizations issued by an agency of the state of Maryland, including but not limited to the Maryland Board of Nursing, until the state of emergency is over. Finally, providers are encouraged in our guidance to utilize all staff in the provision of direct support. This includes the opportunity to explore management and clerical staff as examples. The information that I've just shared is all noted in the guidance and available at that link. Next slide, please. For our guidance related to service delivery in alternative settings and out of state, under DDA Appendix K number 8, services may be provided in alternative site options, including but not limited to the person's home, family or friends' homes, and even staff or direct care worker homes. This may be some options that providers and participants and teams may want to look at in terms of any of the staff challenges, which may provide new opportunities. Reminder, as we just shared on the previous slide, providers can hire those family members and friends as staff to provide care in the family or friend's home. For the DDA Appendix K, number 9, site capacity, providers may exceed the current licensed site capacity and therefore may reduce staffing needs if able to ensure health and safety. Please refer to this guidance, which outlines the specific process that you should follow. Next slide, please. And then finally, in our DDA Appendix K number 10, related to exceed group size and 1-to-1 and 2-to-1 exception requests, the participant to staff ratio outlined in the person-centered plan, such as a 1-to-1 or 2-to-1, or required group size as set forth in the waiver program service definition, may be exceeded due to staffing shortages. Please refer to the guidance that includes the process to seek approval from the DDA for those exceptions to 1-to-1 and 2-to-1 participant to staff ratios. In order for the approval to be provided, we need to ensure the health and safety of the participant. Next slide, please. When exploring staffing options, the DDA continues to encourage teams to use person-centered thinking skills to discuss each person's current service needs, the risk factors, and ways to mitigate those risks, including what technology, environmental, and staff supports will be provided. Providers can reach out and work closely with their regional offices for assistance as needed. We have currently know that our regional offices have worked with several providers and want to again encourage you, if you need assistance with some of those staffing shortages and exploring these options, that you reach out to them. Next slide, please. And then finally, I wanted to share an update related to amendment number 3. The DDA waiver amendments number 3 were submitted to CMS on October 30th. On November 2nd, the DDA, Medicaid, and CMS participated in a call where we provided an overview of the amendment and answered some initial questions from CMS. We were expecting questions from CMS on the amendments this week, and so we are still yet to receive them, and I'm hoping to receive them today. The DDA waiver amendment number 3 proposed effective date is January 1st of 2021. With the approval of the amendment, we will be working on and sharing information and guidance on any amendment implementation and timelines. Now I'm going to turn this back over to the Deputy Secretary to give the COVID-19 regional updates. Next slide.
Thank you, Rhonda. And so as we have been reviewing the number of people who are positive, and we've been giving updates on our webinars. So I want to give you an update as of yesterday, December 3rd, with our COVID-19 numbers. So in the South region, there are 365 confirmed positive folks, 152 negative, 8 pending, and we have had, unfortunately, 19 people pass away. In the East region, we've had 73 confirmed positive, 269 negative, 8 pending, and this is the first time we've reported any deaths in the Eastern region. We've had 2 within the last week. In the Central region, there were 443 confirmed positive, 807 negative, 67 pending, and 27 people who have passed away. And in the West region, there's 96 positive, 293 negative, 6 pending, and we have had 3 individuals pass away. with direct support professionals, South Region, 255 positive and 5 staff have passed away. In the West, 114 positive and 2 staff have passed away. In a East Region, 120, and we've had no staff who have died. And in the Central Region, there is 442 positive and 2 people who have passed away. Next slide. So this is what we've been showing with the pie chart on the left that shows our 95% of our people in services and about 5% have tested positive for COVID-19. And then the chart on the right is a breakout for all 4 regions. And you can see there's been significantly increase in the 4 regions since our last report. So again, I think we're doing well, but I think we're seeing a surge with our population as well as the overall population within the state. Next slide. The chart obviously illustrates, and this is basically from November 13th to December 3rd, we have had 8 people pass away of the 1,015 that have tested positive. And then obviously on the right, we've had showing the number of people who have passed away and the number of people who have tested positive. This is just mind-boggling trying to get our arms around this, and from the state perspective and a national perspective. And again, I think even though we see these numbers, and even one death is in loss is very serious to friends, family, staff, everybody. That I do think that people have been doing a good job. That the numbers are not much higher than what they currently are. Next slide, and we're going to turn this over to Chioma to give us an update on EVV. And I want to congratulate everybody for the hard work that was done with providers, case management, and the regional office staff for being as very successful. Chioma.
Thank you, Bernie. Good afternoon, everyone. So as we look at the chart that is on the screen, this gives an update on where we are with PCPs in the system. It's an at a glance look of the PCPs in reference to electronic visit verification, EVV. So the chart to your left shows the overall state compliance percentage. This data is as of December 1st. We were at 95% compliance across the state. And then when we break the information down by region, the chart to the right shows that information, the percentages that we had for the go live date. So as you all would recall, Eastern and Western went live on 10/1, and Southern went live on 11/1, and our 12/1 go live was for Central just a couple of days ago. So we do know our regional office specialists are working to resolve the final PCPs that are still outstanding, and we are confident that we will be able to have all of that completed before our January 1st deadline. Next slide. So this particular slide is an overview as of December 1st on how we are tracking the percentage of the IVR usage. The IVR is the interactive voice response system that records the calls for the DSPs that are clocking in and out for EVV. So what it's tracking here is the number of client success and number of successful clock-ins and outs. As you can see that it's showing the data across the 4 regions. So the key takeaway here is overall the use of the EVV system is lower than initially expected, as we have a good number of participants that have elected to not receive services during the COVID-19 pandemic. So we, the DDA, are still working to ensure that every participant has an active approved PCP in the system for when they are ready to restart services. So turn it over to the regional directors to share some takeaways from the EVV implementation. And we will start with the Eastern Shores Regional Director, Kim Gachardo.
Thank you, Chioma. Good afternoon, everyone. So the timeline for the EVV implementation that Chioma was just speaking about was obviously very ambitious statewide, and we were so appreciative that our CCSs and providers jumped right in and really helped us and all of our colleagues across the state and the other regions in meeting the deadlines that each of us had that Chioma shared with you. And so the primary lessons learned, and Don, if you could advance the slide, that would be great. Thank you so much. It was so helpful to work with specific CCSs and the corresponding providers in reviewing the service acceptance together. That really led to better understanding of what was being communicated, and this was really important because there are different LTSS screen views for the CCSs, for the providers, and the regional office. So with all three parties together working it out, it was extremely helpful. In that same vein, our regional staff used Google Hangouts to review the PCP spreadsheet information with the various CCSs to really help them determine where the priorities were and necessary action steps in resolving issues. And that also allowed us to be able to pull in the support from Chioma and for other folks within ISAS, et cetera, who could help us resolve some of these issues in making sure that the PCPs were effectively completed. Another thing that we found to be very helpful in our region was having a tool to calculate the hours of service into units, because that's one of the sticking points in working across both PCIS2 and LTSS. That way, both the providers and CCSs were in agreement about what was being authorized. And then our final takeaway was crosswalking the funded hours in PCIS2 and the actual usage of those hours really helped with the authorization decisions based on need. Again, so that everybody was aware of what made sense, what the person actually needed, and was in agreement. So at this point, I want to pass it on to the next regional director, who I believe is Kathy Marshall in Western Region. Thank you.
Good afternoon, everyone. We learned so many lessons from this project with EVV. The first one was we all knew the what, why, how, and what the desired results were. And that was so important for everyone. Everybody knew where we were going, where we needed to be, and what we needed to do. Because of that very clear focus and goals, regional offices were able to reach out and help each other so that we could meet this goal. So that if we lagged behind in any regional office and thought we were getting close to our time, we could very easily share staff. And again, this moves very much toward working as one DDA. We all had to be humble. There was no expert in this. We had not done this before. It was a learning experience for everyone. The key of this was we needed to learn from each other to make sure that the individuals we served got the services they needed, timely, providers were paid, and we knew where we were and what we were doing. It put everybody on the same level playing field, and being transparent made it so much easier to communicate. The ongoing and regularly scheduled communication allowed us to identify concerns as they happened or long before we got to the 11th hour and it became a crisis. That communication has become so valuable that we have continued to move some of our meetings from monthly to weekly so that we can continue to use this very beneficial process. Next slide, please.
Good afternoon, everyone.
Good
Good afternoon, everyone. So some of the takeaways for the Southern Maryland Regional Office are that it was important to set clear expectations and provide guidance and necessary information to the providers, the CCS agencies, and the regional office program staff in order to assist everyone with understanding the process. The EVV webinars, specifically the EVV check-ins with the providers, DDA, and ISIS team, definitely all played an essential role in clarifying information. Also, utilizing tracking mechanisms and meeting regularly with the coordination agencies help to move the process along in a very timely manner. And another important piece is that the regional office, the providers, and the CCSs all being readily available to resolve potential concerns and share information when needed. There were times when the regional office teamed up with CCSs and the providers to have the virtual calls, like Kim mentioned, in order to work through some of the PCPs. I would definitely say that that level of collaboration was helpful throughout the entire process. And finally, ongoing monitoring and communication and collaboration will definitely be critical in maintaining a successful transition into the EVV system. And we're very, very thankful to the coordination agencies, the providers, and our regional office staff for making this a successful transition. I will now turn this over to Bianca Renwick from the Central Regional Office in order for her to share her experience.
Good afternoon, everyone. Like all of the other directors previously, we have similar takeaways, and most importantly for our region, collaboration with the region, the CCSs, and the provider agency was absolutely critical in meeting our goals. It absolutely provided us with a template for future projects, big and small. Like the other regions, we had definitely weekly meetings, which really allowed for us to be hands-on with our CCS agencies, who helped us problem troubleshoot so that we were able to resolve matters as quickly as we could. Our region is looking forward to debriefing with the CCS and provider agencies to discuss what worked and what we learned, so that in the coming months we can continue to assist with any EVV needs and questions that arise. And as you saw from the numbers, we are not at 100% yet. And so the Central Region is committed to work over the next couple of weeks to complete all of our personal support plans so that we can be at 100% completion. And we truly appreciate the support of our partners, our coordination agencies, our providers, and definitely our staff across DDA who pitched in to help us complete this project. Just remember, join us again on the next 2 weeks on December 18th, where Dr. Fetter will be joining us on this webinar. And now I'm going to turn you over to Patricia for questions.
Thank you, Bianca. I appreciate that. Thank you to all of you guys. Have done a great job, providers, case managers, all of you who've worked with the DDA. This is true a partnership. We could not do this without you and the efforts and your commitment. I have lots of questions that have popped in. I'm going to start with a question either for Bernie or Tanya. One is, will our DSPs be considered as healthcare workers and be able for the first phase of vaccines?
Patricia, that is an excellent question. That's one of the questions that I am taking back to the EPI team and the folks that are talking about the vaccination. So we're definitely going to be advocating that that be the case.
Thank you, Tanya. The next questions are for Valerie. If we already made edits to make C days consecutives before you told us to hold off, can we just submit them?
I would suggest holding off still, as I think maybe Rhonda might have touched on. You know, we're still waiting for some additional guidance from CMS, which might loosen that some of those requirements. So I would ask you to continue to hold them.
Okay. Is there any more talk of pushback the cost report grace period, since we are still waiting on CMS guidance about the retainer days, and therefore most of our financial audits have not even closed yet?
That's a good question. So as I have noted before, and I believe that Ron Peel, the DDA finance director, has also shared with providers, is that the deadline is in statute. So DDA does not have any flexibility to change the deadline. However, DDA does have flexibility in terms of the imposition of penalties. So what we have told providers is that, we will not impose any penalties for cost reports that are submitted through to the end of January.
Thank you, Valerie. I'm going to skip and go to, because there's lots of program questions, so I'm going to go to Chioma. And there's a lot of folks that have some questions about EVV and then also LTSS. So I'm just going to kind of LTSS Maryland EVV questions. In the name of transparency, can participants gain access to the systems in read-only mode so as to view info that the systems contain on them?
So that is not functionality that's currently built into the system, but we can certainly share that request with MDH overall. So we will take that back.
Thanks, Chioma. There's one more. This one is an LTSS questions. As early adopters, we have been using LTSS for several months. Prior to September 2020, our program staff could review services and use as program directors were able to see if those program staff declined or accepted those services before they completed the decline or acceptance. Says then, for unknown reasons, they cannot see it, whether it's been accepted or declined, and only that they were reviewed. Why was this feature taken away, and is there plans for this to come back?
So I think what's been referenced there is a very specific question about a very specific part of the system. Just so I make sure that I understand that correctly, if you could please send an email, and I would be happy to follow up and make sure that's not something that is only being experienced by a certain set of users.
Would you like to give your email, Chioma?
Yes, that's chioma.ani@maryland.gov.
Thank you, Chioma. And then here's some program questions. Rhonda, this could be you and then maybe Valerie as well. But in reference to the guidance, it's specific to retainer days, is for COVID-related issues, but January through March, COVID hadn't started. So so it wasn't really clear. So do we have any update on that?
Yeah, so this is Rhonda. I would say that, as we mentioned, we are working with CMS and Medicaid related to retainer days for the Appendix K. Once we get that, those kind of final information and decisions and approval, we'll be updating our guidance and be able to share more information. At this time, COVID-related retainer payments, retainer days, as outlined in the Appendix K, is effective from March of 2020 to March of 2021.
Thank you. And I know you responded, but some people wanted to know where could they find the DD COVID form number 3?
Yeah, that's a great question. You're looking for the form number 3, which relates to the flexibilities for the site exceptions and the staffing kind of exceptions we talked about. Under the Appendix K page, under forms, the last one says DDA COVID-19 requests and notification forms, April 28, 2020. If you click on that, that'll take you to an Excel sheet that includes form 1, 2, and 3.
Okay. Is a team meeting required to modify staffing requirements or to purchase a technology that could assist in service provision? I don't think that we have the time or capacity for a whole lot of team meetings.
Yeah, so that's a great question, and a couple things to keep in mind for everybody. Using person-centered thinking, we talked about really looking at what the person's needs and supports are right now today. So reach out to your CCS, reach out to your regional office, and if you have those immediate needs that are COVID related, And we are doing meetings and calls virtually. If it's an immediate emergent need, you don't have to try to get the entire team together, but you could address it through either the Appendix K authorities in terms of requesting services. If it's COVID related, if it's not COVID related, then you would go through the normal team process.
Here's this is one that came up. Can we obtain a waiver to the requirements of CMT to stay within the individuals for a minimum of 4 hours after administering medications to individuals? This one, we would need to have a conversation with the the Maryland Board of Nursing and have a further discussion. Nobody has requested this formally. You've been the first one. So we will share this with our nurses and see if we can engage with the Maryland Board of Nurses and see what they said. So thank you for bringing that up. Appreciate it. Then let me go to, now back to the chat here. So some people want to know, and I think they're getting, they want to know how do they bill for personal supports for people who are getting state funded monies. Valerie?
Yes. If they transition to the ISAS system, that information, it gets registered just like anybody else in personal supports. The information will be transmitted to LTSS, and there's a state report that is generated or that a provider can generate on a monthly basis, and that serves as an invoice that can be submitted to DDA for payment. Again, if they have additional questions that, they are feel free to reach out to myself, Valerie Roddy at maryland.gov, and they should be able also to talk to the regional fiscal staff.
Thank you. Chioma, this is for you. EVV question. How many times can an agency make changes due to staff error?
So currently, the agencies are to make changes in the system if they notice that your staff made an error in clocking in or clocking out. The limit is going to be 6 manual time entries per month per DSP staff. Being that we are still in the transition into the system, currently Medicaid is not holding to those limits, but they will start holding to those limits towards the earlier part of next year.
Thank you, Chioma. This is a recommendation, is that they are suggesting for our DDA to have 1 or 2 providers present in January to present what worked and didn't work and tips requiring EVV, that this would be very helpful. This is really great. We've done this for families. We just had 2 webinars where families and providers and participants and their direct care staff reported and shared their experience with EVV. So this is great. So Chioma, we should take this into consideration. Let me see. The other one is, and this is this is a Valerie or Chioma. How long do we have to complete the LTSS personal supports billing for November? Since we just went live in November, how long do we have to bill?
I'll start and then I'll let you. So right now, according to the ISAS policy, providers have 2 business days after the month ends to complete all of the information in order to bill. Chioma, would you like to add any details?
That is correct. Beyond for those who went live in November and also those who went live in December, currently ISAS is not holding to that policy yet, as they are extending a grace period for a couple months. But again, similar to the missing time request, early next year, they will start holding providers to that policy.
Thank you, Chioma. Valerie, this one's for you. As we go through our second surge, and some of the people homes have already used their isolation days and are now required to be isolated again, we will need to pay the DSPs, but will not get money to pay for this since days were used prior. any chance we can get an extension of days? And this question was asked 4 times in the chat.
Okay, so as of right now, the isolation days, they are tied directly to what we have in our Appendix K. So the isolation days, providers have up to 21 days, if I'm not mistaken. Rhonda, if I'm wrong, please correct me. You have up to 21 days that can be used. So if I understand it, what you're saying is that you may have a house and with 3 people, and all 3 people up to this point have already used 21 isolation days. So the question is, can there be a second round? At this point, our Appendix K approval only allows up to 21 days, and there are no additional days, but we'll certainly take that under consideration.
Thank you. This is just a statement, a question and a statement. There's a new version of the cost detail on the DDA website under forms. Should providers begin using this version? Yes. We will be putting out a communication today to just remind people where to find it and where it is. But yes, always use the most current version, and we'll make sure that you guys have this information available to you. Valerie, can you talk a little bit about, or either Chioma, a little bit about the difference between EVV, PCIS2, and personal supports when PCIS2 gets turned off and it gets turned on in LTSS for personal supports? There seems to be some confusion.
Okay, so I'll start it off, and again, Chioma is the expert and she can fill in the details. So first and foremost, the services were turned on in LTSS prior. They were turned on in alignment with each of the go live dates. So that was October 1, November 1, December 1. So everybody who was transitioning, that's already turned on in LTSS. So DDA is then, after that has gone live, which we now have all 3 of those rollouts have gone live. So folks that rolled out on October 1st and November 1st, their services have already been ended in PCIS2, and we'll be looking to also end services for those folks who transitioned on December 1st. Even though it's obviously after December 1st, it is retroactive, so no billing can occur in PCIS2.
That is correct. I think that covers the bulk of it. Depending on your go live date, you will be able to bill for that person. Let's say if your go live date was October 1st, you would be able to bill for that person in PCIS2 up till September 30th. Starting October 1st, you should be billing in LTSS. The same for the November and December go live dates, respectively.
Thank you, Chioma. I have another question, and I'm reading it just because it may be helpful for other people. But this is a person whose staff has been clocking in and clocking out, and is not asking for the OTP device number. And as a result, when she clocks in, the time is showing under the wrong client. Why is this happening?
Sure. So for very specific issues like that, we highly recommend you reach out to the ISAS team at mdh.isashelp@maryland.gov. And the reason for that is that there are often situations that are very specific to a particular individual, or their particular OTP assignment, or maybe the way that the DSP is clocking in. So they would be able to reach out to you and follow up and figure out exactly what's occurring there and provide the guidance.
Okay. And then this other one is, why is there a requirement to have billing in for personal supports by the 2nd day of the next month when the billing and payments are processed weekly? It would seem that there would be a cutoff based on a number of days in the past. For example, you can't bill for anything that was not originally reported 45 days after the date of service.
Yeah, so
yeah, go ahead,
Go ahead,
Valerie.
Oh, what I was going to say is that that's a Medicaid policy. We have been asked to look at that, and we have shared that with our Medicaid partners, and they have agreed to revisit that issue.
Thank you, Valerie. Chioma, and this may be a clarification. I'm not sure if it's a question or a statement, but it says, so each staff has 6 errors, but the first staff who makes 6 errors puts the agency under high scrutiny? Question mark.
Sure, that's not quite how it works. So just overall, as your DSP are clocking in and out on a daily basis, they're allowed up to 6 errors or missing times in a given month. So what that means is if there is a 7th one, so after you've exhausted the 6, let's say for DSP staff, John, when there is a 7th one for John, that just means that MDH's ISAS team will review that entry before the system processes it for payment. So every other entry that goes into the system is automatically moving through and being processed for payment. But once you've gone beyond the 6, then MDH teams review that. And the reason for that is to make sure that the provider is keeping up with the compliance requirements and not breaking the necessarily rules and policies that have already been outlined. So that is what those missing time requests mean.
Thank you, Chioma. Valerie, this is a question for you. When will respite go to LTSS Maryland?
Well, respite is already, all of our services are in LTSS. They just have not gone live for everyone. But the services already exist in the system. So I'm not quite sure I understand the question, unless they're talking about the operationalize and where they would bill. Until a provider moves solely, moves completely from PCIS2 to the LTSS system, then they will continue to do their billing in PCIS2 and also through the various invoices that are available.
And then one more, Valerie. Will there be an advance on the 3rd quarter for personal supports?
Yes, we've had to do work. The group that is impacted by that are those folks who transitioned on October 1st and November 1st. And we are actually working on making an adjustment so that there will be an advance. DDA did make this commitment to include an advance in the 3rd quarter to ensure cash flow for the providers that have just transitioned.
Okay, thank you. I'm just reading to see if a PCP that includes behavior support is approved, is the BSS provider free to begin providing services, or do they have to wait until the funding is entered into PCIs2? Rhonda?
Yes, that's a great question. So if a person-centered plan includes behavior support services and it's been approved in the PCP, then you can provide those services and then submit the services through the invoice process. The fiscal staff would then be updating PCIS2, but as long as the PCP has approved you as the provider listed in the PCP for BSS, then you can begin to provide those services.
Chioma, this is for you. It's about clock in, clock out. Why can missed clock-ins only be corrected after 24 hours after the clock out? Sometimes this ends up being much later than 1 day later based on our business hours.
Sure, so that's a good question. When let's say someone was receiving services from 9 a.m. to 11 a.m. On today, if the DSP misses either the clock in or the clock out, the provider is unable to edit that in the system once the other one that was not missed is entered into the system for 24 hours. And the reason that is in place is if the system has already tracked a clock in editing the clock out before the day has ended may conflict with other services that are entered, especially if that person receives services multiple times a day. So that limit is there to wait until the 24 hours has passed so that the system can have updated and processed everything that was entered for that day before the provider agency is able to go in and make any changes.
Thank you, Chioma. And I'm trying to just to see, Rhonda, am I missing any questions? I think I got to the last one. I'm just looking. There was one that we don't really have the answer to. Bernie or Tanya, if you wanted to. How does the mortality rate in the DD population compare to the general population in Maryland? That's a question that came up. And I haven't done a comparison, but I'm happy to take it back, let our nurses review it. And then, you know, we're having Dr. Fetter on the December 18th. We can ask him this question and we can put that in the presentation slot for you all. I'm just looking to see if I missed anything. Oh, here is one. I think that's twice. Will DDA and OHCQ make accommodations with residential SaaS approval during COVID period? We've had submitted a license and waiting for the past 7 months. So DDA has been talking with OHCQ as to what sites they're doing virtually, what sites they're reviewing. And again, we're following the governor's orders. And so at this point, we were resuming things virtually, and then we were resuming things based on critical incidents. I am going to have a conversation with OHCQ next week, and we'll give you an update based on this current search. All right. So this is, I'm not sure. I received a message saying that the provider has exceeded the maximum amount of service. This started with the first clock in December. Notice that November is the last month showing in the detailed service authorization section of the PCP. Why is this happening? Chioma, do you know?
We'd need to take a look at that specific situation. Again, if you could email mdh.isshealth@maryland.gov, and they will be able to compare what's in the system versus what's in the PCP versus what your agency has billed to figure out what's going on.
Okay, and I don't know if this is an EVV question or not, but I'm just going to read it, and this is probably our last one. When an individual receives services in the morning and evening, how do you add the second shift after entering the first? It does not allow a second entry.
So if the services are being clocked in from a phone or using whether or not there's an OTP being used, the system will automatically record both services. But if you are trying to enter that in manually, that goes back to what was mentioned a few minutes ago. You can only, once you submitted a service for the day, you would have to wait 24 hours to be able to make any updates or changes to add a second service or to update a previously entered service if that's what's needed.
Okay, and then Valerie, this one's for you. When will people in South Direction will be implemented EVV?
DDA is still talking with their Medicaid partners, and we will look to, to provide an update in the near future.
Okay, so thank you everyone for joining us. Please remember that on the 18th, the next one, we're going to have Dr. Fetter, who is going to go over the most current CDC guidelines. He's going to talk about holiday gatherings and travel. In the meantime, please wash hands, social distancing, be safe, be well, and have a wonderful weekend. Thank you.